Hello, my name is Melinda Gruber, and I am the Vice President of Continued Care Services at Spectrum Health Lakeland. I'm here today because I care deeply about the quality of life of our vulnerable community members, in particular, people with a serious illness and our older adults. Much of what we just heard affirms what we've likely seen or experienced. Our community's older adult population is growing, and many have multiple chronic conditions. Most emergency department visits are avoidable with earlier and frequent access to primary care. And there is an increasing trend to transfer individuals home from the hospital with supportive services instead of to a nursing care facility. This reinforces the need for a transformational strategy to create a community of care that integrates medical care with social care. So what would the core principles of this transformational strategy be? Our next speaker is a nationally known physician, person-centered care thought leader, and author. Dr. Ira Byock is the founder and chief medical officer of the Providence Institute for Human Caring. Let's listen to Dr. Byock to give us insights into evolving care models that focus on what matters most to individuals, including emotional, interpersonal, social, and spiritual well-being. Please help me welcome Dr. Ira Byock, joining us from Missoula, Montana.
It's such a pleasure to be with you this morning. I believe that what you are doing here in Southwest Michigan has national significance. Dr. Hamill and Lynn Kellogg really put their finger on the challenges that we face and the strategy of transformation in community. I often talk about community as a verb, and what you're showing us is that we are better together and that transformation is possible. I'm going to go like the wind this morning, just setting up a high-level view of the components of transformation and showing what some of the key strategies are that make transformation possible. I want to talk about what we mean by transformation, provide a way of thinking about a whole array and continuum of human caring, look at health system goals for healthcare transformation as a healthcare system, and then look at some of the strategies. I'm going to focus on one key strategy is reclaiming primacy in primacy of primary care, and then end by just emphasizing things that you already know about the importance of focusing on or refocusing on care by us and for us at home. Let me start with a familiar case, people that will, I think, resonate with you. This is a story of Harry and Shirley. Now, Harry and Shirley live together. Harry has Parkinson's disease, a little Parkinson's plus, a little cognitive impairment. He shuffles bent over. Shirley has diabetes, hypertension, macular degeneration, osteoporosis, and spinal stenosis. They are independent at home because they fit together. Why? Because they've been living together for 50 years. Now, the healthcare system doesn't meet Harry and Shirley unless Harry falls and breaks a hip, or Shirley has a stroke because she's confused her blood pressure medication with her diabetes medication, and her blood pressure has been high. They end up in the emergency department and get excellent care in our acute care facilities. But as you know, we could have saved a lot of money as a community had we met Harry and Shirley as an independent living frail elders, met them with home health nurses, case managers, finding that Shirley was confused about her medication, or that there were still floor rugs that could have been removed so that the risk of falling was less. The healthcare system has the best of intentions, but has the wrong models. We in healthcare, including those of us who are medical educators, tend to think about healthcare and teach about healthcare professionals that illness is fundamentally medical. Let me say that as I go forward, this frame shift from understanding that the fundamental nature of of illness is not medical, that it's personal, is essential if we are going to work together as a community. Medicine, social services, community, informal community, to support what all that has been mentioned prior, this goal of allowing people to live fully in place to the extent possible and flourish at home when possible. Illness is personal, not simply for the person who is the designated patient, but for everyone who loves that person. Whenever an individual receives a serious diagnosis, his and her family shares in the illness. This is almost stating the obvious, but it's important as we frame the work ahead today and in the years beyond to understand that. What I mean by transformation is the ability to move from patients to whole persons, from individuals to seeing each individual as a whole person living within a family and in a community or living situation, those social determinants that have been mentioned already twice before. Moving from problems and the problem-based and problem-bound models of medicine to a view of people living with the potential for health and well-being, and from medical treatments to human caring. We've got a lot to talk about. Let me start with the medical model. Let me suggest that this is the box within which we teach young medical and nursing students and others to think. On the upper left of this slide is a copy of a problem list. Now, problem lists are wonderful, and I use them, we all use them, and they are, as a tool, are great, but they've become overlearned. And nowadays, healthcare looks at patients through problems, through the lens of problems. We see the problem list not simply as the table of contents of a medical record, which is already a problem, by the way, but also through the lens through which we see patients. If patients come to doctors and there's no problems, we wonder, well, why are you here? What can I do for you? Let me suggest that as we go forward, we need to think about using the problem list as a tool, but focusing on the continuum of care and of life of the individual within the context of their family and their living situation. And that the goals of healthcare are not simply to fix problems, but to allow people to live as fully and richly as possible through a life cycle and a family life cycle, including illness and caregiving and major life transitions. I've been thinking a lot and writing a lot about the continuum of human caring. And let me, with great respect and appreciation to Abe Maslow, suggest a Maslowian hierarchy in which to think about the work that we do as a health system, but also as a caring community and set of health services. At the beginning, at the base, is the fundamentals of human caring, the essentials. You know them as well as I do. It's providing shelter from the elements. And I'm choosing slide of visuals that draw on our recent experience with COVID, where we've had to adapt and innovate rapidly. A public shelter for providing shelter from the elements, the cold, the wet, providing food for people as a community, not simply as a health system, providing hygiene for safety, but also for the dignity of human caring, keeping company with others, allowing them to know that even if it's via video or through a window, you are not going through this experience entirely alone, the sense of accompaniment. And alleviating symptoms and suffering. These are the human essentials on which we build. We build by providing diagnosing and treating services. We diagnose and treat people's illnesses, their comorbidities, as well as the signature problem that has brought them to healthcare. We also include diagnosing and treating syndromes that cause symptoms and suffering. That's the work that people in my specialty field of hospice and palliative care provide. And we're doing this ever more so concurrently with the disease management teams, the hospital medicine teams, or the cardiology teams, or the oncology teams. Part of what we need to do to reclaim this personalized mode of healthcare, to allow people to live as fully as possible, is to make sure that what we do is actually consistent with what they want, with their personal preferences and priorities. Why? Because illness is personal fundamentally. It has medical components, of course, but we need to make sure that we are doing what people value and honoring their personal priorities. Now, in Providence, and I'm going to mention Providence several times, but simply as an object lesson, as a way that we are doing things that we're offering to others, just like you are doing in Southwest Michigan, solving problems that may be of value to others. We've decided that there are two fundamental components of goal-aligned care. And this is part of our formal strategic plan and our definition of quality within the Providence Health System. The first is that every adult should have on their medical record who they trust to speak for them if they were unable to speak for themselves, through an advanced care planning document like an Advance Directive, or what we've called a trusted decision maker declaration. Secondly, when somebody has a serious medical condition, and particularly when they're going to need an intervention that has some burden or some risk, think surgery or cancer chemotherapy, or other high risk or high burden procedures, we have decided as a health system that our definition of quality requires that there be a documented goals of care conversation, part of shared decision making, prior to that intervention. Now, we haven't achieved that by any means. We're reasonably early on the path, but as I'll show you briefly, we've made substantial progress. In fact, these two measures of performance or quality have become ISFP measures. They are formal, integrated strategic and financial plan measures and performance measures for our clinical teams. In primary care, it's the percentage of people over 65 who have an Advance Directive or a trusted decision maker document on their chart. Well, we've been making some progress, but just look at this. These are actual data. I've just blinded the hospitals. You can see not very much. In fact, in the hospitals, we've barely budged about, the highest of our hospitals are performing at 33% or so. If you look at outpatients, where the ISFP metric is applicable to primary care practices, again, there, if you look really closely, there has been incremental improvement year over year, but nothing to write home about, right? We decided that insanity is doing the same thing over and over again and expecting different results. A quote attributed to Einstein, he didn't actually say it, but it still resonates. So we decided to change it up. We had a primary care doctor who, on a phone call with me one day, said, "Ira, can't we just create a simple one-page Advance Directive that can be completed in a single visit?" Well, yes, we actually can. When we looked at things, we saw that some of the barriers to completing an Advance Directive had to do with that menu of choices about whether you want CPR or mechanical ventilation or medically administered nutrition and hydration. And nobody can really understand and predict what they're going to want at a future time. I wouldn't be able to do that. You'd have to tell me more. Was I just in a car accident and had a head injury and I might wake up and be able to do the crossword puzzles again in a few weeks or months? Or do I have advanced cancer and my body is so riddled with metastases that there is no sense, no reasonable expectation that I'm going to achieve another, once again, a quality of life worth sustaining? So that's one barrier. But the second barrier is that many people don't have access to those witnesses or a notary that are required in advance directives. But they can, on any given day, tell you who they would trust to speak for them if they were unable to speak for themselves. It may be a spouse or an adult child or a close friend. So we designed or redesigned our Advance Directive to be what we're now calling an easy form. It has just 3 sections. First, tell me one or more than one person you would trust to speak for you if you were unable to speak for yourself. Two, don't give me actual menu of services or treatments that you would want, but just the general sense. Do you want everything possible, even if your quality of life is not felt to be worth sustaining to others? Or do you want to balance the quality of your function and quality of life interacting with others with the intensity of medical treatments? Or are you somebody who just wants to focus on comfort and allow nature to take its course? If you don't know, well, that first box says, I don't know. I'm going to trust my future doctors and the person I named in the part 1 of this form to make those decisions on my behalf. And third, sign it in the presence of a witness or notary. The trusted decision maker form substitutes a clinician's signature, attesting that the person has capacity to make these decisions, but only in a few states does that have legal standing. In most states, you still have to have witnesses or a notary, but still, quite simple, could be done in a single visit. The second one is having a documented goals of care conversation on the chart for any patient in an ICU for 5 or more days. It doesn't have to be done by the critical care doctors. It could be done by the hospital medicine doc or the primary care physician, a model that I'll come back to in a bit, but it must be done for the person. Now, this wasn't just our idea. We went to the critical care literature using Choosing Wisely, this aggregate of medical specialties, saying what they believe are important elements of quality and things that patients and doctors alike should be wary of. And here you note 5 critical care societies said we shouldn't be continuing life-sustaining treatments without having a goals of care conversation and allowing people to know what's achievable physically and functionally, and whether that is still consistent with their personal values, preferences, and priorities. At Providence, we made it easy to do this. We tweaked our health systems, various electronic health records, to make it easy to document and then later to find those goals of care conversations. No longer within Providence is it legitimate for a hospital medicine doc to say, well, I think my colleagues in the last hospitalization had that conversation, but I can't find it. Yeah, you can. In seconds, it's right in front of you in the patient's chart. We also have been educating our doctors and nurses and social workers and chaplains about how to have these conversations and how to use the EHR, the electronic health record tools that we've created to make the right way the easy way. So let's look at this. In a single year, and this is current data, in a single year, look at the bar in blue here, the ISFP metric. You can see a rapid rise. We are actually changing medical practice in a way that is consistent with goal alignment, because we've made the right way the easy way, using data in a real-time way to drive continuous quality or continuous value improvement. Now, I won't go through all of these lists, but this is, again, actual data from a single hospital in 2020, meaning that most of this, more than 2/3 of this, happened during COVID. These are Press Ganey patient satisfaction questionnaires, and we've analyzed whether people with serious illness, and we've done as good a job as possible to compare apples to apples here with people with serious comorbidities. And we've looked at whether a goals of care conversation is associated with a higher or lower Press Ganey satisfaction. I should mention, by the way, that these goals of care conversations were not done by palliative care teams. We actually took out those that were performed by a palliative care team to look at how the general health system is performing. Look at all those lists of actual Press Ganey topics: likelihood of recommending the hospital, the degree to which staff showed compassion, the response to your complaints, attending to your special needs, including you in decisions, managing your pain, nurses keeping you informed. I can go on and down the list. And then look at the right, and you can see that all of these had positive, statistically significant changes in the direction of higher patient satisfaction with those having a goals of care conversation. And the magnitude of the change in Press-Ganey, if you're familiar with Press-Ganey scales, these are big changes, 13% from 7% to over 13% changes with simply listening and eliciting people's preferences. Assisting with life completion. This is part of human caring. And that involves, and this is something I've been writing about for years, the nature of opportunity. Now, I don't want to put rose-colored glasses on serious illness and dying, but it is a normal time in human life. And there are things that people value during this time of human life. Communicating bad news and sad feelings, a sense of completing your affairs, yes, your business and legal affairs, making sure that the deed to the house or the title to the car is transferred to whom you want it, but also, and your passwords, give them your passwords so they can get into your bank accounts and close your darn Facebook account. But also completing your personal affairs, making sure that there's nothing critically important left undone or unsaid between you and the people you love. I've written a book called The 4 Things That Matter Most. They aren't things at all. They're 4 statements or sentiments that are of value to people that patients and their families have taught me over the years. Please forgive me. I forgive you, because let's face it, there hasn't been a perfect relationship in the history of humankind. Even the most close and loving relationships often have history of hurt feelings or misunderstandings or times when things didn't go well, sometimes actual real transgressions. Please forgive me, I forgive you. Thank you and I love you is so often like stating the obvious, but boy, is it ever important to say those things before one dies, to say them out loud. That's a gift in one's memory that keeps on giving. This last part of life offers a chance to grieve together the impending loss of life and relationships, to review one's life, to tell one's stories, to explore those realms of connection to something larger than ourselves that will endure into an open-ended future, a sense of connection to our God or to nature or to our families who will live on for generations and we feel connected to, or to our culture. This sense of fostering well-being, I mentioned early on that we need to move away or get beyond the bounds of the problem-based and problem-bound model of caring to foster well-being and foster human flourishing. Well, what does that mean? What is health and well-being when somebody is seriously ill? I've been thinking about this for many years. You know, Sigmund Freud was once asked, Dr. Freud, he was walking through a crowd, at least as I heard the story, and somebody called out to him, Dr. Freud, how do you define mental health? And he tossed off the answer, the ability to love and to work. Not bad. When you think about it, for an adult to be physical or to be behaviorally, mental health-wise healthy, they don't have to be in a good mood. They don't have to be joyful, but they have to at least be able to love others and go to work. For health, for well-being, I would add that they actually occasionally need to have the ability to laugh, to experience some degree of joy. If you can work, love, and at least occasionally experience joy, you make my criteria for being well. Well, how about when somebody is seriously ill or has living with the frailty of age and work isn't really even relevant to their stage of life or the situation that they're in? My answer is that well-being involves the ability to love, to feel loved, and to feel joy, at least occasionally. This is a photo of my dad, Seymour Byock, during the last months of his life. Dad was dying of pancreatic cancer. My dad was a lusty man. He loved life. He's holding in his hands my eldest daughter, his only grandchild at the time, Leela. Leela's now over 40. My dad hated the fact that he was dying. But in this moment, if you could, I hope you can see this well on your screen, he is ecstatic. He's locked eyes with Leela, and they are joyful together. My dad was well within himself during this period of time that he was dying. Indeed, relationships, human connection is essential to human well-being. It's become very hard during COVID, but this is not, while COVID made the problem and the barriers at scale, they've been barriers that many of us are used to. Not uncommonly, I meet patients who, prior to COVID, who were states away from their loved ones, and they were seriously ill and the family couldn't visit. So we were using technology at the time, FaceTime or just phones, and connecting people to one another. We can help people have a felt, authentic sense of connection, knowing that they are loved, that they can love, be loved, and at least occasionally experience some semblance of joy. And finally, because we're all in this together as families, as friends, as social networks, as communities, well-being involves a sense of honoring and celebrating people, our relationships, and our shared lives. This we can do as a community. At Providence, we've been using this Get to Know Me poster that we've continued to tweak, and we're trying to take digital at the moment. But even during COVID, these posters, which are kind of oversized printed posters, can be completed by families and then put outside of the room or within the room of a patient who is even in isolation. They're particularly useful when patients have dementia or some degree of delirium, or they're in an ICU and they're unable, because of the serious nature of their illness, to speak at all. This is a way of delivering patients from anonymity, reminding everyone who enters the room, from the housekeepers to the head of critical care, that we're caring for a whole person, that this is not who they are in that bed now, that they are more, they have a continuum of life. They have people who matter to them and for whom they matter. We have done this even during COVID. Here's Margie Ullman speaking with her family from a hospital bed, and her son-in-law visiting with her. I met Margie's palliative care doctor, who said it was just this, that we honored and celebrated Margie for the remarkable person that she was. It's been a barrier, this Zoom mentality or Zoom constraints, but it has been a medium through which we can honor and celebrate people. We've done this with healthcare as well. Here's Nurse Nancy, her real name, letting a patient in a long-term care facility know that she was loved. Our chaplains, our clergy, have found innovative ways to allow people this sense of connection, honoring and celebrating people through the end of their lives. I want to return to health systems and the goals of transforming health systems. You know this, I hope, the quadruple aim: improving patient outcomes, including satisfaction, patient experience, lowering the per capita costs of care, because at 18% of our GDP, healthcare's costs are unsustainable and are having erosive effects on other important social needs, and improving provider experience so that we are not burning our providers out. I want to choose just a few of strategies to look at. This was the hardest part of crafting this presentation, was taking out things I'd love to talk to you about, and hopefully we'll have time in the Q&A to expand the conversation. Personalizing the EHR, I'll spend just a few moments on that. Routinizing person-reported information, I'll spend more time on that. And then reclaiming the primacy of primary care and looking at innovative models of home caring. Okay, personalizing the health record. We're doing it at Providence. Systems across the country are doing it. It's a long journey, but we're beginning to deliver people from anonymity within their own electronic health record. Health records have been poorly designed for years. In fact, we're engaged in a transformation of health records. Before I quit practice, I believe we're going to see the beginnings of people owning their own health record, not hospitals or health systems or your doctors. That you're going to own your own health record. Here's a sample, something from Patient Wisdom, a company that vends to hospitals and health systems ways of personalizing their health record. What a health record of the future could look like. This actually is existent now, but few health systems have used it. Personalized reporting of information is transformational. It's a methodology for identifying medical and non-medical problems. By the way, you may know of this as PRO, or patient-reported outcomes. I'm not comfortable with that term, because so much of the information we're seeking isn't outcome information. It's simply personal information about the patient and their experience. But that's the methodology. It's a methodology for identifying both medical and non-medical problems, simplifying screening and monitoring of physical health, of functional capacities, of emotional, social, spiritual, and distress and well-being, of assessing for social determinants of health, and providing relevant data on person's own priorities so we can measure what matters, and accelerating that transformation from the problem-based and problem-bound medicine model to personalized health, from individual care to the promise of population health. This is transformational because the main way that American healthcare deals with unmet needs today is we don't ask. Because if we did ask and we found enormous problems within a patient's life, their unmet needs, social or medical, we would all end up with moral distress because we don't have ways of addressing those needs. So currently we don't ask. And under the fee-for-service traditional way of financing American healthcare, that works just fine. Because if you don't ask and a preventable crisis happens, well, the health system gets paid for managing that crisis. As we move from volume to value in the financing of healthcare, suddenly it behooves us to know about those unmet needs or those emerging problems before they become a crisis. So just imagine with me that every appointed medical visit, not the urgent care or the emergency visits, but every appointed medical visit, though the annual Medicare wellness visit is an example, patients used their MyChart or their home-based tablets resources, or at their office in the waiting room were given a tablet that had just a few questions. And I'm going to go through them like the wind to save time, but you'll get a sense of this. On the right, I have where in the structure of medical and social determinants these might fall. And those are just suggestions. Many of them fall in more than one category. Do you feel safe at home? Yes, no, unsure. Do you feel safe in your community? Do you have enough to eat? How often does pain make it hard to do things that you want to do? How often are you bothered by little interest or pleasure in doing things? How often are you bothered by feeling down, depressed, or hopeless? Some of you will recognize that these items are drawn from things like the PHQ-9 or other standardized assessment tools. Are you at peace? This is a single item that has been validated as a spiritual screening tool. Are you having sexual problems or questions? We don't ask this in primary care very often because there's not time, but it's important to people. And it can improve their quality of life or uncover really important stressors in their personal life. Do you have problems with washing? Something about, critical activities of daily living and independence. Do you need help in getting dressed? Do you have bowel problems? Do you worry about wetting yourself? There's been multiple studies that show that with frail elders, that incontinence is one of their biggest concerns. incontinence and transportation. I remember as being stunned as a family doc that these were the biggest concerns that many of my frail elders had. Are you able to shop for yourself? Are you able to manage your finances? IADLs, right? Are you able to buy medicines, or are you skimping on medicines because you don't have the money? Do you sometimes have to skip doses? Are you a caregiver yourself, caring for family members? And we know that caring for a family member is almost a diagnosis in and of itself, that caregivers are under enormous physical and emotional strain. Are you lonely? You get the point. Now, can you imagine if you were in a primary care office or a medical home and every patient you saw for an appointment, you had a graph over time of some of these key determinants, and you could go on with your usual quick visit if none of these met or were rising or indicating of a crisis that was apparent. Think about Harry and Shirley if they were seeing a primary care physician and having this. I don't have time to show you the outcomes of some of this methodology, but they're quite dramatic and positive. Let me return then to the primacy of primary care. What are doctors for? Well, under current medical model, they're for saving lives, preventing and treating illness and injury, extending life when cure is not possible, alleviating symptoms and suffering, and optimizing function and independence. Under an expanded model that I showed you, they're also for improving the quality of individual and family well-being, assisting in treatment decisions, accompanying people through these difficult times of illness and disability, and supporting people to thrive within their families and communities. Oliver Sacks, this was published posthumously in the New Yorker, but he wrote a wonderful article about telling. And he reflects, even before my own medical education, I learned that essential truth about doctoring from my parents, who were both physicians, that being a physician involves much more than handing out diagnoses and treatments. It involves playing a role in some of the most intimate decisions in people's lives. This requires considerable amount of delicacy, human delicacy and judgment, no less than medical judgment and knowledge. Now consider that statement with this study. Now this is a study in a VA hospital in the Bay Area of California, which used lay health workers and Veterans Administration patients with cancer to document goals of care conversations. They needed to do this because there were very few goals of care conversations documented in the patient's charts. I won't belabor this study, but look at the results. They went from 17.5% of goals of care documentation to over 90%. Satisfaction was high, all of this statistically significance. In the days, 30 days before death, hospice use was nearly doubled, or 1.5 times. ED use fell to near nil. Hospitalizations were diminished, and the costs were dramatically saved. Now, I would celebrate this, this study, and in fact, I do. This incorporating lay health workers into cancer care increases the documentation, patient satisfaction, reduces healthcare costs, all well and good. But as an old primary care physician myself, I have to wonder, well, then what is a doctor for? I have to tell you that outsourcing goals of care conversations to lay volunteers feels to me like misunderstanding the doctor-patient relationship. It feels, outsourcing goals of care conversations within a doctor-patient relationship seems a bit like outsourcing sex in a marriage. I mean, isn't that one of the main reasons we came together? Isn't this part of what it means to be your doctor? I think it is. When we look at what primary care doctors have the highest satisfaction, that quadruple aim of feeling professional satisfaction or even joy at work, it's the concierge doctors. They have far fewer patients on their panel. They get to spend more time with their patients, and they fulfill this notion of job satisfaction, that special relationship between patients and families that is good for both. Why? Because at the end of the day, we are all whole persons who are caring for whole persons. I'm going to conclude with two examples of caring for us, by us, at home that you know and are frankly using within your communities. The first is the naturally occurring retirement community, where people come together informally or formally to share services, to contract for things like plumbing and electrical services and transportation, Uber and the like. It's kind of, think of Angie's List for a community that intentionally comes together to buy things together, to share recommendations, and to support one another, sometimes with volunteering. So maybe people as part of this NORC are a retired plumber who can do some work, and a retired bookkeeper who can help with taxes, right? This is people working together in community. Think of community as a verb here, not simply as a noun. Community, living in community with one another, not simply in proximity to one another. And then something you're well versed in, the PACE programs. And I know the Area Agency on Aging is a host for several PACE programs. These programs bring together those services that meld the attention to people's personal needs, their ADLs and IADLs and transportation, with the medical needs that people have. These are currently for people who are dual eligible, right, for Medicare and Medicaid, and meet skilled nursing criteria under Medicare or Medicaid, but they needn't be. In fact, PACE, we know, is a sophisticated and cost-effective model. I can show you the data for that, but let me show you this. Just a couple of weeks ago, an IPO, an initial public offering for InnovAge, raised $350 million to take PACE private. This is a key indication that the market realizes the value of this model of care. Finally, I'll just end where I started, with the assertion that transformation is possible. I'm lecturing to you this morning from Missoula, Montana, my adopted hometown. This is a place where we take caring for our own seriously, just like you do in the St. Joseph area of Michigan. You are creating models and data and resources for us, and I hope that what we've learned here in Missoula also can be of value to you. So thank you very, very much for allowing me to share my thoughts and experience with you today, and I look forward to your questions. Thank you. I want to mention, by the way, that we're going to be putting some handouts in the chat box as links so that you can read further, and I hope they're of value to you as well. Thank you. Okay, I have one question that's come through, and that is, you mentioned the importance of clinician well-being as part of the quadruple aim. How can we reduce burnout among nurses and social workers and others? Great question. I would start by saying that burnout is not simply about the poignance of the work that we do. It is about not being able to feel we're giving care at a level and a quality that meets our own internal standards. So the best way to address burnout is to help nurses and social workers and doctors as well, frontline clinicians, to be providing excellent care, making sure that they have the time and have the resources, the tools that they need to meet their own internal standards, because we are whole persons caring for whole persons. And the biggest source of burnout, and this includes in the realm of not only acute care, where I worked for years, but also in hospice and palliative care, that we need the staffing and we need the resources to be able to provide excellence by our own internal standards. If you do that, then the level of stress, moral distress, and burnout drops precipitously. It's not about focus groups or about support groups only. It's about making sure that clinicians can provide the best care they possibly can. Other questions? Palliative care is still underutilized, and the teams tend to be small. Why is that, and what can be done? You know, most health systems still have a sense that palliative care loses money. The fact is, if the accounting is accurate, palliative care does not lose money. It is, in fact, a significant contributor to the fiscal bottom line. Within the Providence Health System, we've brought sophisticated financial impact analyses to the actual impacts of palliative care. We've done it mostly in the hospital, where the hospital is already at risk under DRGs for the patient's total cost of care for that hospitalization. And we have shown that unbeknownst to the CFOs of our health system, palliative care has been saving millions and millions of dollars. And we've shown them first through modeling, statistical modeling, but then through actual program expansion and different deployment of palliative care, that we can achieve millions of more dollars of savings by using palliative care earlier in the course of any hospitalization for people who are seriously ill. This has resulted in the Providence Health System substantially investing in expanding the service line of palliative care. As we move from fee-for-service, from volume to value in healthcare financing, we're doing the same thing in outpatient palliative care, community-based, office-based, home-based, and telehealth-based palliative care. So that's the main reason, is to show that there's a financial advantage to doing the right thing, which is allowing palliative care to concurrently care for people undergoing treatments for their serious illness. As a question or a comment, many of our residents go to the neighboring state of Indiana for medical care. I do have a problem getting an appointment with my Michigan primary care physician, often having to wait a month or more for an appointment. The question, I guess, asks itself, why is that the case? And this is a real problem that Dr. Hamill and other leading physicians or leaders of the health systems need to address. The fact that that's occurring, it will drive costs, diminish quality, cause unnecessary crises to occur and complications in people's medical condition. I don't have a solution for you because I'm not there. And this is a problem that's happening in many places in the country, but it is a problem that diminishes not just quality, but value. When you can't get an appointment, costs actually go up, not down. And so as we move from volume to value, that's the sort of thing that absolutely needs to be addressed. I've been asked, where can we get a copy of the easy form? Well, we will put a link to one of the easy forms that we use in the chat box. I think the link that we're going to give you is to the California model of the easy form. But I have to tell you, and I've been working with national attorneys, that these easy forms, while this one will have California at the top, these forms are legitimate, fully sanctioned advance directives in all states that we've looked at. They have every element of a power of attorney for healthcare and the basic elements of a living will. So I'll be surprised if your own legal counsel in your organization does not say we can take and adapt this easily to our own jurisdiction. You mentioned the Institute for Human Caring. Can you tell us a little bit about what it is and what it does? Oh, I'd be delighted to. We hardly have the time. So we have a website, Providence Institute for Human Caring. You can always just Google us. We are a team of about 25 people, There are several physicians. All of us have palliative care background, nurses, social workers, but also educators, the Lean Sigma, system management and program management people, as well as data wonks. We have 8 analysts and software engineers working with the Institute to crunch data and to provide dashboards to show our health system how we are doing month over month, quarter after quarter, on some of our key priorities of having advance directives or trusted decision makers involved, how we're using goals of care conversations and what the impacts are, how we're deploying our palliative care teams, which are limited and need to be deployed in ways that best meet people's needs, and so much more, working on patient-reported information projects and the like. You'll see in our website, which is mostly public facing, that we've also developed a podcast called Hear Me Now. We have a Hear Me Now project that is a StoryCorps based project, the National StoryCorps organization, which I love. Well, we adapted StoryCorps for our system and the communities we serve to elicit and record interviews between 2 people around key experiences with healthcare, and that's available to you. We've created something called the Coronavirus Chronicles as a time capsule for the human experience that we're all living through during this remarkable, unprecedented time in our lives. How can concierge medicine be cost effective? Well, it is cost effective when the health system bears financial risk under ACO situations or Medicare Advantage situations, or Medi, where you're owning risk for the patient's total healthcare costs. Then seeing primary care as key to that. I have this dream, and I think I forgot to mention it, where when a patient is hospitalized, the primary care physician comes into the hospital or Zoom visits into the hospital to have those goals of care conversations, so that what we're doing is consistent with what the patients want, what their values, preferences, and priorities are. Who better to do that than the patient's own primary care physician? This is so key. Concierge medicine looks expensive in the fee-for-service model, where volume is so important, but in the next normal, in the new normal of value-based healthcare, concierge medicine can be totally cost-effective and heighten satisfaction for all. I think that's all the time that we have. You can continue to put questions into the box, and they'll be there for conversation. Let me close from where I started, which is it's a true privilege and honor to be part of the faculty today, presenting with Robin Goldman. And I think it's just remarkable what you're doing as a community in Southwest Michigan. Thank you for the work that you do day in and day out. And thanks again for allowing me to share my thoughts.
Thank you, Dr. Byock. Your outstanding energy and encouragement help us know that transformation is possible. And it starts with the principle of whole person care. Realizing that medical care is just a small part of what provides quality of life and what makes people well. We are learning what happens at home, around the kitchen table, with friends, family, and neighbors greatly impacts the health and wellness of individuals and families in our community. The mission of Spectrum Health Lakeland is to improve health, inspire hope, and save lives. And we are excited to engage in the road to transformation and the development of a community of care, because we know that we have to transform healthcare to meet the needs of our community. And this transformation fits with the health system's priorities to focus on value over the volume of care, to expand more services into the home and through virtual care, to ensure all community members live long and healthy lives, and to build partnerships and new relationships. We are working to implement the evidence-based, age-friendly health system approach called the 4Ms to frame care around an individual's mobility, mentality, medications, and what matters most to that person. And we understand that the financial and social service needs in our community are extreme and impact health needs in disproportionate ways. We are committed to addressing racial health disparities and inequities in our community. And we work to remove barriers to healing and wellness with our community partners. We can see that integrating the healthcare system's care with home and community-based services will provide a much more comprehensive approach to whole person care. Let's consider this compilation case. Last year, Charlotte found that she could hardly care for her husband of over 65 years, Charles. He was close to twice her weight and had quickly gone from being able to care for himself to needing her assistance nearly all of the time. Taking him to doctor's appointments was nearly impossible and exhausting for both of them. So when a crisis happened, Charlotte called 911. Charlotte called 911 approximately 15 times in 6 months. At one point, when Charles was hospitalized, additional referrals were made to Caring Circle and Area Agency on Aging. Through shared care management, home-based primary care, and connections to additional services such as Meals on Wheels and the Community Action Agency, the couple had additional equipment in their home, delivered meals, medical visits to their home, and friendly callers checking on their condition. The next 6 months had no 911 calls. This outcome was made possible by a care team that asked, "What's happening outside of the hospital and in the home? What matters most to this couple? And what is needed to address their needs before they become emergencies?" Just over a year ago, I completed an 18-month Health and Aging Policy Fellowship. During that time, I had the opportunity to interview aging and health policy leaders from around the country about the challenges and opportunities when integrating health system care with community-based services to improve care overall. Some of the key opportunities that I studied are the same opportunities our community has now when creating a community of care. First, improve access to home and community-based services that wrap around the medical care and support the seriously ill individual and their family. This can make all the difference in the world and keep people at home and comfortable instead of facing the trauma of emergency department care and hospitalizations. And the COVID-19 public health emergency has accelerated our efforts in this area through increased virtual visits to people in their homes, increased referrals to community-based services and supports, and enhanced care coordination. We can build all of that we've learned over the last year. Second, implement financial models that ensure consistent and high-quality home-based services and supports are available. With a shift to value-based care, the time is now to work with Medicare, Medicaid, and insurance companies on alternative payment models and demonstration projects. The Emergency Triage, Treat, and Transport Partnership is one example of how Spectrum Health Lakeland is working with community partners to avoid emergency department care when care can be provided in the home or at a clinic instead. Third, focus training for families as well as unpaid and paid caregivers so they are competent, comfortable, and confident. So much can be done if you have the knowledge, skills, and confidence to care for your family member, friend, or neighbor. Putting into place 24/7 virtual resources such as telehealth are available through hospice care and home care and provide an added level of support and assurance so that individuals can remain at home if that is their wish, even when medical conditions change. And fourth, use technology to develop whole person communication systems, care plans, and records so that all those involved in supporting an individual and family through medical, social, and home-based services are coordinating care, transforming the current medical record to a whole person health record. Leveraging these key opportunities, our Spectrum Health Lakeland, in partnership with our community, can provide better care and quality of life at lower costs while improving the satisfaction for everyone involved. This transformation is possible, it is cost-effective, and it is the way to provide the best care. Intentional collaborations and partnerships with our local community-based organizations, faith communities, educational institutions, and municipalities are critical to creating an integrated and comprehensive community of care. We are excited about the road ahead and traveling it together. Spectrum Health Lakeland greatly values its relationship with Area Agency on Aging. And now it's my pleasure to introduce my colleague and my friend, Christine Van Landingham, Chief Operating Officer at Area Agency on Aging.